She has a fellowship in reproductive medicine, infertility training at Brussels, Belgium, diploma in gynec endoscopy here, Germany, diploma in USD, Chennai, editor decision making in infertility, director International Fertility Academy, editor decision making in infertility.
నా పేరు డాక్టర్ అపూర్వ పల్లం రెడ్డి. ఐ థింక్ కొంచెం ఇన్ఫార్మల్గా ఈ కాన్వర్సేషన్ ఉంచేదానికి ఐ వుడ్ వాంట్ టు కంటిన్యూ విత్ a little bit both in English and Telugu. I hope that is all right with all the audience here. I think all the speakers who have spoken before me have made my job very, very easy because nenu ippude em maatladabothunnano next 20 minutes lo most of them have covered about it in their topics, but I will try and assimilate all of it and put together. Resistant PCOS. So this is a concern for most of us. So whenever we decide that okay, mana dagariki patient ochindi, mana medications ivvali, ovulation induce cheyali ante, how do you take that choice? Do you just flip a coin and say that okay, first patient ochiniki clomiphene citrate istamu, next patient ochin vallaki Letrozole istamu? If it's heads, I am going to start with 2.5 mg, or tails I am going to start with 5 mg. It's not like that. We come up with a strategy that what kind of drug and what is the dose that we are going to give. Dr. Jyoti had very clearly elaborated. I think ovarian resistance or clomiphene citrate resistance anedi manam decide chesedaniki mundu we have to see what is the dose that was given to them in the past. 1 year back, 2 years back, in case if they have taken medications, 5 mg of Letrozole తీసుకున్నారు, they have not ovulated, please don't go ahead and start with the same medicine again unless there has been significant weight loss or they have had other adjuvants in the course of point, they have made some amount of lifestyle changes. In case if they have done all of this, there is no harm in starting that dose all over again. But in case if they have not, malli ade dose repeat cheyadamu, malli months on months waste cheyadam anedi, it is not a great way to start. Now sometimes mana all medications anni ichamu, despite that ovulation doesn't happen, we know that we are in trouble. What do we do next? అసలు ఈ ప్రాబ్లం పీసీఓ పేషెంట్స్లో ఎందుకు వస్తుంది అనేది మనకు అర్థమైతే దెన్ వీ విల్ బీ ఏబుల్ టు కైండ్ ఆఫ్ కమ్ అప్ విత్ అ బెటర్ సొల్యూషన్ ఫర్ దెమ్. మనందరికీ తెలుసు మోస్ట్ ఆఫ్ దెమ్ ఈవెన్ ఐ థింక్ ఏఎంహెచ్ అన్న టెస్ట్ రావడానికి ముందు ఎల్హెచ్ ఐ థింక్ వాజ్ అ హ్యూజ్ బిగ్ టెస్ట్. ఎవ్రీ మంత్ ప్రతి నెల వీఆర్ గెటింగ్ FSH అండ్ LH టెస్ట్ డన్. దట్ LH ఎక్కువ ఉంది అంటే ఈవెన్ ఇఫ్ యూ డోంట్ డూ అ స్కాన్ వీ యూస్ టు టెల్ దట్ ఓకే షీ హ్యాస్ PCOS. Now we have a better test to kind of give us an understanding or diagnosis about PCOS, that is your AMH. So AMH ekku undi ante PCOS undedaniki possibility undi ani. Now AMH and LH ee rendu they increase the stromal volume, cause obesity. For some patients there is thin PCOS also present, and ultimately I think andariki almost about 85% of women with PCOS have elevated androgens, any kind of androgens. E 5 or 6 factors put together is what is hampering us from achieving a good ovulation in PCO. So if we are able to tackle all these parameters, then I think it's going to become, a smooth walk for us or a smooth sail for us to achieve ovulation. One point I would want to make here is, మనం అందరం చెప్తాం ovulation, follicular study every month cheyali, we are seeing in all of this ani. And for men we tell that 3 months, it takes almost about 80 days for sperms to form and so on and so forth. But we need to remember that even for women it takes almost 80 to 120 days for a recruitment to happen. మనం అందరం చూసుంటాం సెకండ్ డే మనం స్కాన్ చేసినప్పుడు కొన్ని సైకిల్స్లో AFC చాలా బాగుంటుంది, కొన్ని సైకిల్స్లో ఇట్ విల్ బి వెరీ బ్యాడ్. So why does it happen? Because that cycle is a poorly recruited cycle. It's possible that 3 months back or 4 months she has had fever, or she had some other variation or hormonal abnormality because of which the recruitment was bad. So if I need to achieve ovulation for a patient, let's say 3 months from now, I should have had a good recruitment in the last couple of months. Keeping that in mind, so elevated AMH, అన్ని PCO పేషెంట్స్కి మనకి హై AMH ఉంటుందని కాదు. I think the maximum that I have seen for a patient was about 28. And there was a patient even with 4.5 or 5 AMH also who was still having a PCO morphology on the scan and who was having difficulty with ovulation. But in the high AMH unna patients lo, AMH in itself will cause a follicular atresia or antral follicular atresia. It will just not let it grow. FSH, మనం ఎంత ఎక్కువ మెడిసిన్ ఇచ్చినా FSH రిసెప్టర్స్ అనేవి ఫాలికల్స్ మీద లేకపోతే it will not be able to take the drug into the follicle, it will not let it grow. So AMH అనేది ఈ antral follicle atresia cause చేస్తుంది. It's ironical because it's being produced from the preantral follicles and it kind of causes the depletion or inhibits them from going. So AMH ఎక్కువ ఉన్న వాళ్ళని ఎట్లా ట్రీట్ చేయాలి, or how do we treat? As Dr. Jyoti has excellently spoken in her lecture, extended letrozole protocol అనేది is a very, very I think safe, simple and cost effective way for us to start off. See, మనం చేయడానికి చాలా చేయొచ్చు, ఇంజెక్షన్స్ చేయొచ్చు, or we can do a whole lot of fancy things, but what is the easiest and simplest and cost effective thing that we can do for a patient? Just increase your letrozole for another 3 to 5 days. So already మనం 5 days ఇస్తున్నాం. 5 mg again is something that I start for all patients. I don't think I have given 2.5 mg even for a 45 kg or a 50 kg patient. And as gynecologists, manaki there are only 2 things that we fear about. Okati ureter, inkoti OHSS. I think this is one thing that we are always scared about, but we have very, very effective ways about handling OHSS. And in simple IUI, I think it's very, very unlikely for you to really have an OHSS kind of situation. So do not worry about it. 5 mg is a good dose for you to start off with. And then, yes, go ahead and take it up to 7 days or 10 days to see and decide if ovulation avutunda leda anedi. Remember, ovulation is not the final endpoint. Pregnancy is the endpoint. Why aren't we using clomiphene citrate for 10 days or 15 days? Or why aren't we using letrozole, let us say, for 15 days? Sare 10 రోజులు ఇచ్చాం కదా, ఇంకొక 5 రోజులు కూడా ఇచ్చి చూద్దాము, అది కూడా ఇంక్రీజ్ అవుతుందా అంటే it is not going to happen like that. Because the T-half of letrozole is about 45 hours. Remember again, letrozole is an aromatase inhibitor. So మీరు 10 రోజులు letrozole ఇచ్చారు అంటే follicle అయితే మీకు కనిపిస్తూ ఉంటుంది, it will be growing. Probably it will become 18 mm, 19 mm వరకు కూడా వచ్చేస్తుంది. But E2 will not grow because your estrogen is not being produced. E2 రాలేదంటే endometrium thickness కూడా రాదు. So if the lining doesn't build up, your implantation is not going to happen. Fortunately for us, unlike clomiphene citrate, which has almost a 14-day T-half, letrozole has only a 45-hour T-half. So technically మనం ట్రిగర్ ఇచ్చేదానికి ఒక 1 day ముందు, even if we kind of stop your letrozole. So 10 days కంటే ఎక్కువ it's definitely not recommended. And 13th or 14th day, if we see the follicular scan and see that egg development మనకు మంచిగా అవుతుంది అంటే, then we will be able to go ahead, give the trigger and plan for pregnancy. So that is the reason why almost an ovulation rate of 92%. So this is all in resistant patients. 92% is achieved, a cumulative pregnancy rate of 31% and a live birth rate of almost 25% can be achieved. Now, as I said, when it's too good to be true, we need to make sure that the endometrium also is kind of following it up. And I think this is a good space. Someone was asking about estradiol valerate. This is a good place where we can consider using estradiol, or your Proganova, as what everybody says as that దీనిలో మనం ఈస్ట్రోజన్ యాడ్ చేయడం వల్ల సమ్ అమౌంట్ ఆఫ్, అంటే డామినెంట్ ఫాలికల్ వచ్చిన తర్వాత కొంచెం ఈస్ట్రోజన్ యాడ్ చేసుకోవడం వల్ల లైనింగ్ తొందరగా వస్తుంది. అగైన్ ఎగ్ డెవలప్మెంట్కి, ఓవులేషన్కి, ఇంప్లాంటేషన్కి 7 days టైం ఉంది. So this is the time that we need to build up your endometrium for implantation.
Letrozole and clomiphene, I think before letrozole became so popular, I was using clomiphene citrate with tamoxifen. 40 mg of tamoxifen, 100 or 150 mg of clomiphene citrate based on their weight is what I was using at that point. But I think letrozole vachin tarvata, the number of patients who have ovulation resistance is come down significantly. But if you do intend to use, I think using clomiphene 100 mg and letrozole, but again, clomiphene only for 5 days. And that too, don't go beyond 100 mg. And letrozole you can use for 5 days or 10 days based on how you feel she is responding. And that is something that you can definitely try, because both of them have different mechanisms of action. PCOS గురించి మాట్లాడి metformin గురించి మాట్లాడకుండా ఉండడం అనేది జరగని పని. And I am always a little skeptical about literature. You know, every time, you know, some speaker comes and, you know, foreign speaker, national speaker, they'll come, they'll present very fancy data, you know, randomized control trials, cohort studies, meta-analysis, so on and so forth. But I think some amount of it, we should trust in our practice, in our experience also. Because I think evidence goes up, comes down, goes up and comes down. It always comes in waves. There was a point when we believed there's nothing better than metformin for PCOS. There was a phase that we saw that everybody said, you know, metformin is nothing and, you know, myoinositol is the thing and, you know, that is the only thing that you need to take. And now again, everybody is like, no, okay, metformin is something that you need to do and myoinositol probably is not very effective. So evidence is good, believing in it good, taking some points from it is good, but that doesn't mean that you should close your eyes and ears to your general practice and go ahead with it. I completely believe in metformin because the physiology behind it is unparalleled. And if we have to just simply talk about metformin also, 80 days of use. Otti metformin ankoni oka 250 mg or 500 mg ala icheste, it is not going to be sufficient. A minimum effective dose is 850 milligrams. And this you can kind of increase up to 2 grams per day also based on the tolerance of the patient. You can just take it as a step up. So again, dose duration, 80 days, that is at least 2.5 months. So 2 months ichesi, next month than anyway ovulation start ayindi, I mean day 2 vachi ovulation ayesariki oka 15 రోజులు పడుతుంది గనుక ఆ టైం వరకు అచీవ్ అయ్యేది 80 days is a good time. So 2 cycles of metformin is mandatory if you want to see any results in it. So in this simple study which evaluated, let's not look at metformin valla ovulation avutundi ani evaru cheppatledu. Okay, please be clear about that. Metformin to part 2, you have to give either clomiphene or you have to give letrozole, what you're comfortable with. But metformin is the side actor who is going to make the main lead look good. He is like the Katappa for Bahubali who is going to kind of help or enact in their goal. So in this study, we can significantly see that joint group ante metformin plus lifestyle changes, control group ante only lifestyle changes. So lifestyle changes, weight loss anta aina kuda ఇన్సులిన్ రెసిస్టెన్స్ లెవెలు, ఎల్హెచ్ లెవెలు, ఎఫ్ఎస్హెచ్ లెవెలు ఇవన్నీ బెటర్గా ఇంప్రూవ్ అయింది. కొలెస్ట్రాల్ లెవెల్స్ ఇవన్నీ బెటర్గా ఇంప్రూవ్ అయింది ఈజ్ ఫర్ ద పేషెంట్ విత్ ద మెట్ఫార్మిన్ గ్రూప్. ఈవెన్ ఏఎంహెచ్ లెవెల్స్, నౌ యూ కెన్ సీ హియర్ నార్మల్ వెయిట్ గ్రూపు, ఓవర్ వెయిట్, ఒబేసిటీ. ఒబేసిటీ పేషెంట్స్లో యావరేజ్ ఏఎంహెచ్ వాస్ 12. But 80 days of treatment with metformin got down the AMH to 7.5. Ante ovarian reserve taggipinda? It's not that. It has reduced the number of available antral follicles and it is going to improve the FSH sensitivity for what we are giving. Again, you know, I candidly keep telling my husband, whenever I praise you in front of someone when you are not there and I come back home, you invariably have a fight with me over something which is very silly. So metformin is also like that. You know, don't think that it is all good and, you know, it is not going to have any negative impact or there is no this thing. One very important factor is vitamin B12 deficiency. We know that there is nausea, we know there are diarrhea issues. All of that is because of the intestinal motility. You can consider adding Sporelac or any probiotic for them to improve. But apart from that, vitamin B12 deficiency, especially ippudaithe అందరూ వెజిటేరియన్స్ అందరూ వీగన్స్ అయిపోతున్నారు. ఐఎమ్ ఫీలింగ్ వెరీ బ్యాడ్. ఐ హోప్ ద ట్రెండ్ ఇస్ నాట్ యాజ్ బ్యాడ్ ఇన్ హైదరాబాద్ యాజ్ ఇట్ ఈస్ ఇన్ బెంగళూరు. బట్ ప్లీజ్ బీ వెరీ కేర్ఫుల్ అబౌట్ వైటమిన్ B12 డెఫిషియన్సీ బికాస్ దే విల్ హ్యావ్ సిగ్నిఫికెంట్ వీక్నెస్. దాట్స్ అబౌట్ ఎలివేటెడ్ AMH. నౌ LH ఎక్కువ ఉంటే, సో AMH ఎక్కువ ఉంటే మెట్ఫార్మిన్ యాడ్ చేయండి, ఇట్స్ డెఫినెట్లీ హెల్ప్ఫుల్. లెట్రోజ్ ఎక్స్టెండ్ చేయండి, డెఫినెట్లీ హెల్ప్ఫుల్. LH ఎక్కువ ఉంటే basically if you can see the 2-cell 2 gonadotropin theory, LH ఎక్కువ వచ్చినప్పుడు androgens ఎక్కువ ఫామ్ అవుతాయి and FSH తక్కువ ఉన్నప్పుడు it's not able to convert all these androgens into estrogen, so it keeps throwing it into the bloodstream. దానివల్ల is why you have hyperandrogenism, and this hyperandrogenism is what will cause your anovulation and everything else. Now androgens have ovarian origin, adrenal origin and peripheral. Peripheral is where you lose weight and everything, it will come down. But what would you do with the ovarian and adrenaline one? I think all of us have used OCP at some point to kind of reduce LH. It definitely reduces LH, no doubt about it. 2 months of using OCP for someone who has significantly elevated LH, let's say 15 or 18 or 20, is going to be beneficial. Kani, PCOS and metabolic syndrome are very, very synonymous these days. So we do know that hypertension, cholesterol levels elevation, diabetes, obesity, anni parameters PCO patients lo untai. So when you are giving OCP, please make sure that you get a small checklist done like this, wherein you are evaluating them for the risk of a venous clot or a thrombosis. So, మన ఎంటైర్ కెరియర్లో ఐ థింక్ ఒక్కసారి అయినా కూడా చాలు, ఇట్ ఈస్ ఎనఫ్ టు రెడ్యూస్ అవర్ లైఫ్ స్పాన్ బై a couple of months. So it's not a bad idea to have a checklist before you go ahead and start. You don't need to fill it. You can just give it to your patient or you can give it to your staff and they can get it done. And if you feel there are more than 2 risk factors that are there, you should rethink before going ahead and continuing OCPs for them. Steroids అన్న మాట మనం విన్న వెంటనే everybody kind of gets worked up, including doctors, but it's not always bad. There is a reason why they are there. And yes, using dexamethasone in small doses of 0.25 mg at bedtime for about 10 days from day 5 to day 15 can reduce adrenal androgens and thus help in achieving ovulation. Generally, to kind of touch about antioxidants in PCO. Antioxidants, I think, affect everything. They kind of are bad for everything. Likewise, especially for PCOS, it's a very, very pro-inflammatory condition. So, antioxidants use cheyadam anedi manchide. కానీ ఏ యాంటీఆక్సిడెంట్స్ యూజ్ చేయాలి? CoQ, inositol, D3, omega, melatonin. So if you have a look at what is the impact on what? Testosterone levels, triglyceride levels, insulin resistance and BMI. I am not talking about ovulation because ovulation is a final aspect. These 5 parameters or 4 parameters, androgens tagite ovulation easy avutundi. Triglycerides or cholesterol tagite weight తగ్గితే ఓవులేషన్ ఈజీ అవుతుంది. ఇన్సులిన్ రెసిస్టెన్స్ తగ్గితే ఓవులేషన్ ఈజీ అవుతుంది. సో దీస్ ఆర్ ఆస్పెక్ట్స్ దట్ యు నీడ్ టు ఫోకస్ ఆన్. అగైన్ ద డైలమాస్ ఆఫ్ a student, good grades, enough sleep and having a good social life. You can never have all the 3. You have to sacrifice one. Either you can have good grades, have a good social life and you won't be able to sleep at nights, or you choose the ones which are important for you. Likewise, I think when you're looking at your gonadotropins also, you have to look at basic dose, FSH or LH, FSH or HMG, recombinant urinary, or what are the main regimens that we have. Again, I almost felt that Dr. Jyoti completely spoke whatever I wanted to talk regarding PCO resistance gurinchi ani. But yes, again, giving you a pictorial representation of the same thing. FSH threshold is required, so you need a certain dose to kind of achieve it. FSH window, that is the duration that you need to kind of give for you to be able to achieve it. ఇది మనకి న్యాచురల్గా అవుతుంది లోపల జనరల్గా. దీన్ని మనం పెంచాలి, or if you need to achieve multifollicular genesis, or if you do it అంటే, then you give a higher dose for a longer duration of time so that you get more follicles for going through and the remainings undergo atresia. Quickly going through the protocols. So I think conventional step up, step down, ivanta evaru ippudu cheyadledu. This is like, Dr. Deepthi is also agreeing with me. Nobody does it anymore. The first cycle when you use gonadotropins is going to be the toughest cycle. And that is the cycle you need to prepare your patients mentally. 3 రోజులన్నా, I mean, so yeah, we give 5 days of letrozole and then we start them on gonadotropins. We always use a combined protocol itself. So I tell them 3 days aina pattachu, 7 days aina pattachu. Dose 150 to basic line lo start chestunnamo. Tell them I don't want to start with a high dose because I feel it might have side effects. We will see what is the best dose that is possible for you. If you tell them in the beginning itself, they will not be disappointed in case if you feel they don't achieve an ovulation. So tell them in the beginning itself that what you're doing. Because if you 5 రోజులు 7 days ఇంజెక్షన్స్ ఇచ్చేసా తరాక ఎగ్ రాలేదమ్మా, నెక్స్ట్ సైకిల్లో నేను మీకు మళ్ళీ డోస్ పెంచ్ చేస్తాను అంటే, మేడం ఈ సైకిల్లోనే డోస్ ఎందుకు పెంచలేదని అడుగుతారు. సో యూ టెల్ దెమ్ ఇన్ ద బిఫోర్ హ్యాండ్ ఇట్ సెల్ఫ్ దట్ యూ డింట్ వాంట్ టు డూ ఇట్ బికాస్ you value for their health and you don't want to start a very high dose for them right away, is going to be a better approach. Honestly speaking, we have even started off with 150 international units also, but I think 75 is a safe space, and we have to welcome PC Mahapatra sir. Thank you so much, sir. It's a pleasure. I'm glad you're I have the pleasure of talking in front of you at least for another 8 more minutes. Resistant PCOS అంటే మనం 150 యూనిట్స్ ఇచ్చేసాం, మెట్ఫార్మిన్ ఇచ్చాము, వెయిట్ లాస్ చేయించాము. We've done everything, other than changing the husband, we have technically done everything for the patient and she is still not got pregnant. Will anyone of you have it in you today? We have not, ovulation avaledu inka IUI sangat tarvata. So will you have it in you to tell the patient, let's do an IVF? Ferty9 అయితే అందరూ ఓకే అంటారు, రెస్ట్. So it is not that fertility specialists always believe in IVF or that gynecologists are more inclined towards an IUI. మనం ఏం చేయగలము అనేది shouldn't decide what we do for the patient. We can do a whole lot of things, but that doesn't mean that we should do everything for the patient. What is best for the patient? It is not a bad decision to kind of decide that you want to do an IVF for her. We've had a patient, she was about 95 kg, married for about 5 years, never achieved ovulation. We gave her oka IUI cycle ki we went ahead and we did, and she required almost 200 international units for about 8 days, 5 days of tablets and so much to just get 1 follicle or 2 follicles, I think. We did an IUI and she didn't get pregnant. So in a certain profile of patients, it is not required for us that andariki 4 cycles of IUI ayin tarvate IVF cheyali leda andariki oka 10 years of marriage tarvate IVF recommend cheyali anem ledu. If the patient is an older patient, so it's not just sarle 35 undi kada, AMH 6 undi, inka chaana time undi anedi kudaradu, because quality also matters. It's not just about quantity. Tubal factor, someone who has only 1 tube, that there is an endometriosis, that pelvic factor is there. Male factor, I think all of us have seen patients wherein the woman has even undergone surgeries and still the husband has not got a semen analysis tested. Forget about a DFI. So if there is a male factor, and he is requiring very high doses of gonadotropins for achieving ovulations and has long-standing infertility, 10 years, 15 years of infertility, and never got pregnant even once. So in these cases, I think trying to, keep repeating the same things, even if you achieve an ovulation, even if you do an IUI, the probability of pregnancy is going to be only about 10 to 15%. So don't waste more time on it. So you can still consider doing an ART in certain patients for resistant PCO. I strategically kept drilling as the last thing that we are going to discuss on PCOS. Do I believe in drilling? Yes. Do I believe we should do drilling for all PCO patients? No. Has the role of drilling in current practice come down? Yes. Was it very effective in the past? Again, yes. Because when my mom is also a gynecologist, she is from Nellore, Andhra Ipudu. But so in her generation, I think the marriages were happening at a younger age. Women were planning to get pregnant earlier, and the scope or use of laparoscopy was much more then. Considering drilling at that point was a much better option. If a patient is coming to you at 32, okay, even if her AMH is 9, there is no reason why you should consider doing a drilling, because in another 2 years, as another previous speaker of mine said, in the ekku AFC unna kuda, it's possible that the baseline might be very low, and it's possible that she might end up with a premature ovarian failure very soon. So these are my 5 tips for considering drilling. డెసిషన్ ఫర్ డ్రిల్లింగ్ అనేది పోర్ట్ వేసేదానికి ముందు తీసుకోవాలి. పోర్ట్ వేసిన తర్వాత అరే కొంచెం అనెస్థెటిస్ట్ చెప్తారు, స్పెషలీ మేడం కొంచెం ఓవరీ బల్కీగా ఉన్నట్లుంది కదా మేడం అంటారు, దెన్ అసిస్టెంట్ అంటారు, దెన్ వీ డ్రిల్. దట్ ఈస్ వాట్ హ్యాపెన్స్. సో ప్లీజ్ డోంట్ డూ ఇట్, అండ్ ఐ హోప్ దెర్ ఆర్ నో అనెస్థెటిస్ట్ ఇన్ ద క్రౌడ్. బట్ ఎస్, డెసిషన్ ఫర్ డ్రిల్లింగ్ హ్యాస్ టు బీ టేకెన్ బిఫోర్ యూ పుట్ ద స్కోప్ ఇన్. ఓన్లీ ఎంత పెద్ద ఓవరీ అయినా కానీ, ఎంత ఏమేజ్ ఉండనా కానీ, ఇఫ్ షీ ఈజ్ ఓవులేటింగ్, యూ డోంట్ నీడ్ టు డూ డ్రిల్లింగ్. If the age is less than 30, if she is having significantly elevated LH, and she has a short duration of fertility. Yesterday, in my OPD, we did a fallopian tube testing, hycosi for a patient. Tubes superb, spillage was good and everything else. And then I was explaining to her, tubes are great, and then she started crying loudly. I was like, what happened? Is it hurting? Is it paining? Didn't they give you injections, on and so forth? She was like, no, madam, naake enduku ila avutundi madam, pregnancy enduku naaku kavatledu. She's married for 1 year. She's 26. Her tubes are good, sperm parameters are good. I literally lost it. But still, you had to kind of keep your cool. So, shorter duration of infertility, for those kind of patients to consider a pelvic factor or to kind of improve the ovulatory effect, yes, you might consider. But for someone who's married for 7 years, 8 years, 10 years, please don't do it. Dr. Shashank had discussed regarding how you need to do the drilling. I am scared to put on, the day when it comes when I gain weight, because if I gain weight and if I tell my patients lose weight, I feel, they are not going to agree to it at all. It is impossible to lose weight. I feel it's so difficult. I feel sad to tell patients to lose weight. So just don't tell them lose weight. Do something about it or help them do it. Orlistat is a great lipase inhibitor. It is not orlistat anundigani, it's not a statin kind of thing. It's a lipase inhibitor. You can use it for women who are planning for pregnancy. Welcome, Shanta ma'am. Thank you so much for coming over. And again, yes, I have another 1 more minute before finishing off with you. So orlistat is a good anti-obesity medication which you can kind of go ahead and give at least for 2 months. It is equally effective as metformin with lesser side effects. Be open to the idea of, even if you have to recommend a bariatric surgery for a patient, it's not a bad idea. It's very difficult. It's very difficult to lose weight, and you say 130 kgs unna patient ki nu weight loss ayyi ra ante how is it even possible, or how is the patient going to feel? It's, we might feel that it is like this, but I have had patients who've cried because senior consultants have told, no weight loss avakapothe no pregnant kavamma, no inga vellesra. They've told it, and which is true. But it's not something nice you would want to hear, especially when you are struggling with weight loss. So I think we should have a great program for it. I'm done. Decision Making in Infertility, this is a book that myself and Dr. Rajiv, we had authored. And I think this is one of our proudest moments. I was randomly kind of going through stuff, and then I got this algorithm. So the entire book is about 100 algorithms about managing different case scenarios, right from evaluation to fertility. It is available on Amazon, so I'll be more than happy if anyone sees it. So it's very simple. There are things which are evidence-based. This is my last slide. So there are things which are evidence-based, and there are things which require a little more evidence. So clomiphene citrate kani, obesity kani, resistance unte, we can consider use metformin, minoxidil. Remember the dosages. Anti-obesity medications like orlistat can be used in a certain dose to lose the weight. Patients who have elevated DHEAS, which is adrenal source of androgens, we can consider using baseline steroids. Women with elevated LH, androstenedione levels or testosterone levels, we can consider using 1 or 2 cycles of OCP so that the total androgen levels will come down. Thank you so much for a patient hearing. I always love to come to the Telugu states and speaking, because this is such a pleasure to talk to a full house. And I have to thank Dr. Jyoti Budi for calling me here. She is truly an absolutely loving person and very, very kind-hearted. Thank you so much for the entire team.